Welcome to Human Rights Here Now, a program of the Alliance for Human Rights in the Santa Cruz County. Today's program is about dying with dignity, a rather serious discussion, but we hope that you'll find it very informative and a great education for all of us. The way it came about is that my friend Erin and I lost our siblings in the same year last summer. And we had talked about the differences in our experiences with our siblings. And as I discussed this with our team at the Human Rights Here Now team, in the beginning of this year, I would say, they encouraged me to do a program. And so it took a while, but here we are in October of 2014, about a year and 3 months after our siblings passed away, and it's time to do the program. And we're very fortunate to have with us Dr. Chalea Massion. She is a physician who worked 28 years as a family physician, then was for about 6 years a hospitalist in Santa Cruz, and now is a chief medical director at Hospice of Santa Cruz County. Welcome, Erin, and welcome, Dr. Massion.
Thank you.
What we'd like to do is, Erin, we'd like to start with the story of your brother.
Okay. Like Mathilde said, the summer of 2013, we both had siblings pass because of cancer. And when we compared the two deaths, we thought, what a difference that my brother had to suffer as much as he did, and that her sister was able to choose the option of taking some medication and ending her suffering. So my brother was in his mid-60s. He had had a stroke and was therefore incapacitated and living by himself, and developed some bone cancer. And for about a year, his son, who was in his late 20s, was his chief caregiver, and my sisters and I tried to support him as much as we could. He underwent radiation for the cancer, which had moved into the bones of his chest mostly. And after about a year of radiation, he opted to have no more medical procedures. He was not one that wanted to fight this cancer. He did not want to have any chemotherapy. And so from about Christmas until the time he died in July, he was without any medication. And what I observed is that the suffering that he went through was very intense. And although it was his choice, he and his family finally got together with the doctors and said, I need some pain medication. So the only thing that Mike had was some kind of patch on his skin that prevented him from having pain. And little by little, we watched him get frailer and frailer. He was living by himself, like I said. His son would come over and try to give him some food. And probably it was about April or May when, having visited him, I decided that I would call Mike's physician and hospice and say, what's the next steps? My brother is obviously dying. He's in a lot of discomfort. He cannot continue to go this way. What should I do? So the people that I talked to from hospice recommended that with the physician's order, that eventually they would get to the point where Mike would need some more care than he was getting, and that I should call when I thought that that time would come. So I was very concerned that his son was taking on this burden, and so I stepped up and started taking more and more of an active role in Mike's care. And at that point, I hired some people to come to his home and try to cook for him and clean for him. And probably the most important thing that happened was that he had a visiting nurse come to his house. And this man was somebody that Mike really trusted, that he had seen him before in the past through the doctors, and that this man became a trusted person that Mike could talk to, would listen to. So about mid-June, early June, before he died in July, I called that nurse, and I asked him to meet me at the house so that I could have a discussion with Mike about what are the next steps. My fear was that he was home alone and that his son was going to walk in someday and find this sad scene where my brother had died all by himself. And I didn't want that for my nephew, and I didn't want it for my family, and I certainly didn't want it for Mike. So the last weekend that Mike was home alone, I went to see him, and it was a Friday morning, and he was so weak and so sick, and he had not eaten for about 2 weeks. And he was in his bed, and he was asking me to help him. And I said, well, what do you need? And he needed me to physically help him get to the bathroom and all those kinds of things. And I said, this is not working. It's not working for you. It's not working for your son. It's definitely not working for the amount of care that you need. It's not fair for you. So I asked him if he wanted any kind of support systems, like, do you want a counselor? Do you want a priest? Do you want me to go get a Buddhist? You know, somebody to talk to. And he said, he looked at me very sincerely and he said, well, you know I'm not going to get better. And I said, yeah, I'm pretty sure that we all know that now. But what are the next steps? What can we do? So I called the visiting nurse, and he was amazing. He came over to our house, to Mike's house, and he went in the room and closed the door. And for about a half an hour I waited. And finally he came out and he said, Mike has agreed that he should go someplace. So I called the doctor. The doctor had a place where Mike could go and said, I will bypass all the rigmarole of having him to have to go to the hospital and get checked in and get a doctor's opinion about how sick he was. So we were able to get him into a wheelchair. The people that were coming to take him came. I had to personally put him in a wheelchair and take him downstairs because they could not transport him from the house to the van. And then we proceeded to go to this place. When we got to the place, I sat with the incoming staff and said, my brother is in the end stages of cancer. He needs comfort care at this point. What can you do for him? And so they agreed that they would take him and provide him with just what he needed so that he had no pain. Well, as the afternoon progressed and they put him in a room, the caregivers was one nurse on staff for a whole ward of people that ranged from people with senility to very seriously ill people like Mike. And I was kind of taken aback that he was put in a room with another gentleman who had dementia. And the nurses were in and out of the room. There were 2 beds separated by a curtain, and that was all that was separating him from this man, who needed a lot of encouragement to get up, and they were talking loudly and helping him get his shoes on, and then arguing with him and back and forth. And here Mike was laying in his bed waiting for his first shots of comfort, his morphine or whatever they were going to give him for pain. So it took a couple hours for the nurse to finally get it settled down. The LVNs were in and out of the room. They were coming into the room. There was closets in the room where they had to get other things for other patients. So I pulled the curtains closed. I tried to make it quiet in his room, and I tried to turn the TV on to some kind of music station so that he could listen to music. It wouldn't work. He didn't have a radio. So little by little, I was getting more and more upset, and the nurse came in and she actually hugged me and said, I will do everything I can so that he doesn't feel pain.
And then at some point...
I had to leave. I had to leave him there.
Yeah. And then so they came and they gave him food, right?
The next morning.
Yeah.
I came in about 9 in the morning. I probably left about 7 at night, and there were 2 young social workers who pleasantly greeted me and said, we're going to feed him breakfast. And once again, I looked at them and said, do you know why he's here? So the nurse that had been on all night had not been told at all that he needed any kind of morphine. He went all night without any comfort care. And once again, there were people in and out of his room all day. So I went to the administrators again, and I asked that he be moved to a private room and talked to the social workers about the fact that he was there only for comfort care, that he had not already, it had been 2 weeks that he hadn't eaten any food, that he was there just for comfort so that he could die. And at the end of that morning, probably about by 2 in the afternoon, I would say, they had moved him into a quiet room. Nobody was in and out of his room. The original nurse that had come, that had hugged me and told me that she would take care of him, apologized that whatever had happened on the chart had not gotten relayed to the nurse that night. So Mike stayed in this place and lived for another 3 weeks. No food, no water, just morphine. And we got a call at about 2 in the morning that my sisters should come, and he died without any other incidents after about 3 weeks of just the morphine. So it was very hard to watch it happen, and I would say that the hardest thing for me was that the communication breakdown and the fact that the people that were there, of course, they wanted him to get better. They wanted to take care of him. That's their job. But nobody relayed that this was comfort care, that he didn't need food. He didn't need lots of noise and changing of his sheets and all the things that they were going to do for him. And you know, God bless those little social workers. They had every good intention, but it wasn't anything that he needed. Yeah. And so it was very, very difficult to watch that happen.
Is this a common experience that you encounter before hospice comes in with people? Is this a special situation?
Well, I certainly have heard stories like this before, and it's clear that it's not only suffering for your brother, but it's suffering for you and for your family. Yeah. To feel that he's somewhere and he's not getting the care that he wants, and he's not getting the care that he needs.
Right.
So right. I think that's
that. He would have loved to have stayed home and been able to have this happen, but there was no way. We couldn't provide that service for him in the place where he was living. So ideally, of course, he could have stayed home and had that same comfort care at home with the quiet and the, but the situation was that he had to go to this place. So comparing that to what happened before, it was difficult to go through.
Yeah.
Mm-hmm.
And it was,
yeah,
it was
so
frustrating for a lot of us.
Yeah.
Mm-hmm.
Yeah.
Mm-hmm.
Could you relate some of your experiences with your patients, and how hospice, what role hospice plays in giving the palliative or comfort care to people?
Sure. So I am a little curious why your brother did not receive hospice services, either at home or when he went, it sounds like he maybe went to a skilled nursing facility.
Yes.
Was where he died.
The hospice was on board at this place, talking to the nurses, and I guess probably communicating with the doctor, who was his primary physician. But initially, like I said, initially when it first started, there was such a lack of communication. Eventually, my other sister said she had talked to hospice. She never met with them. She never saw them at this place. But the nurse, the primary care nurse that was so encouraging to me that she would do everything to make sure that he had no pain, she obviously was in communication with hospice. So that's all I can say. We never saw them. So
usually hospice is more visible
Yes.
than in your brother's situation. And for someone to qualify for hospice care, we say that the length of their life needs to be 6 months or less.
Yes.
So and if somebody has metastatic cancer, as your brother had, we don't know how long they'll live. We don't have any completely accurate ways to predict.
Right.
However, I think his prognosis would have fallen within that time, with 6 months or less.
Right.
So I would say, more ideally, he would have started receiving hospice services at home.
Right.
And that may or may not have enabled him to stay home to die. It might have. There often is a trade-off between freedom and safety, I would say, and his freedom to stay at home and the safety of being in a place where he could have around-the-clock care.
Exactly.
And as you said, you didn't want to have your nephew come in to find your brother dead.
Absolutely.
And having your brother die, die.
Exactly.
Yeah.
Exactly.
And we know the way that someone dies not only tremendously impacts the person who dies as they're dying, but the way that they die and the symptoms that they have as they are dying tremendously impact how the death is perceived by the family and by the grief process that they go through.
Right.
We know that families who feel that their loved one has had good pain control, has been free of nausea, has been comfortable, has been in a soothing place. We know that families tend to be much more at peace when someone dies, and that makes their grieving process less complicated. It still can be profound, but there aren't all those tensions around, oh, he was in so much pain, or oh, her last hours she was short of breath, and things that are just heart-wrenching to see. Right.
We could not provide that service of having somebody live with him. He didn't have the means. So, I appreciate that the doctor let me jump past that, let's go to the hospital, put him in ICU again, which he had happened several times, and then just put him in this place where there was to be comfort care. Under his management is what I understood. And it was, like I shared, it was just so hard to see how difficult it was to get that actually to happen. So that was my frustration, and I felt for him. And the fact that he lived for 3 more weeks is testimony to what you just said. Sure, he hadn't eaten for 2 weeks already, but we didn't know how long he could live. So we were all very surprised that he stayed as long as he did.
We do know that when someone has their symptoms controlled, that they actually may live longer than otherwise, because they're not so stressed. Their body isn't so stressed.
Exactly. Yeah. So
that brings me to a couple of questions. We already said, how does a person get referred to hospice? And then later we want to talk a little bit about what people can do to to declare what they would like to have happen at the end of their life. But how do people get referred to hospice? By their doctor, by self-referral?
Yeah, both of those ways and other ways. We have, at Hospice of Santa Cruz County, we have a wonderful intake department, and the phones are ringing through the day, and it often is a family member who requests a hospice evaluation for someone in their family. Sometimes it can be the patient themselves calling. Sometimes it's their primary care physician. Sometimes it's their nephrologist or cardiologist. You know, someone involved in their medical care, a physician involved in their medical care. So anyone who has a serious illness can request a hospice evaluation, and then we will send an experienced nurse to that person wherever they are, at their home, at a nursing home, at an assisted living, and the nurse will make an assessment and talk with a medical director. And if we feel that that person, with their whole picture of illness, has a life expectancy of 6 months or less, then they are eligible for hospice. So that's the process. If we evaluate someone and they have a prognosis, their life expectancy is more than 6 months, then we have a transitions program for people who aren't within 6 months of dying, but maybe a year or longer, to have them connected with services, to have them connected with support during that transition time.
Right. Now, you referred us to reading a special report by the Institute of Medicine, which was published on September 17th, and which I found extremely valuable in understanding situations like hers, but also the good situations in the dying process for people in the United States. And I was very impressed with that. And maybe we can talk about that a little bit.
Of course. About
some of their key findings and actually their recommendations. They have 5 different categories. And the first category is to have a person centered and family-oriented care, which is, I understand, a completely different view from what we had even probably 20, 30 years ago. Could you explain a little bit to us what the Institute of Medicine tries to say with that?
Yes, I first want to say that it's a wonderful time for the two of you to be having this program, because I am absolutely, what can I say, overjoyed about the Institute of Medicine publishing this book. It's actually a book of several hundred pages, and I just feel that it's so timely that there is a need to talk about our end-of-life care in the United States, because I think in so many ways it's so misguided, and we devote tremendous resources to someone at the end of their life, but often that can mean prolonged hospital stays, a lot of time in emergency rooms, time in skilled nursing facilities. We spend a tremendous amount of energy and resources, finances on it, and I think too often, people don't get the care that they really want. There's research that shows that most people want to die at home if you ask them, but unfortunately in the United States, most people die in a hospital or in a skilled nursing facility. And it would be transformative in our society if we were able to create support systems that would have allowed your brother to stay home. That's where people are most comfortable, that's where they're most soothed, that's where they can be with the people they love more easily. So the Institute of Medicine report, Dying in America, it has multiple sections, and I think the first section that you mentioned, Mathilde, is delivery of person-centered, family-oriented care. And I'd like to say that that many of the things that they talk about in this report, I think would be really appropriate for people to have from the time they are born until the time they are until the time that they die. So, you know, person-centered care means it's not a recipe of how to take care of somebody. It's not a cookbook. It's not an algorithm. It's not a lot of boxes. You know, if you have this, then you get this. It's really begins with a conversation with that person. What's valuable to them? You know, what are the symptoms that are most bothersome to them? You know, what are their priorities? What are their values? And that is tremendously important. Family-oriented care means that the healthcare system supports the whole family, and I think it's very important in my mind to say that family is not often just someone's biologic family. It may be their family of friends. I think often it can include their beloved companion animals. People really seek comfort from them, you know, during the last phase of their life. So it's designing a system that is very specific to that person and to that family.
And then there's a second part, which I think everyone at home should be aware of, is the physician-patient communication about the advanced care. And so briefly, let's talk about that and maybe show some slides about how people can get information about the three parts, which are the advanced care, advanced directive, and the 5 wishes and the POLST. So why don't we start with talking about the POLST?
Okay, so POLST is a funny acronym, and it stands for Physician Orders for Life-Sustaining Treatment. They chose this incredibly bright neon pink color to have it printed on, so it would stand out in somebody's medical chart. And the POLST form is designed for people who are maybe in their last year or two of life. And on just one page, it goes over a set of very important choices for someone. The first section is about, does somebody want cardiopulmonary resuscitation? Do they want CPR? If they stop breathing, or if their heart stops, do they want you know, the medical team to rush in, or the paramedics to come to their home and do chest compressions and give breathing support? The second section has to do with, do you want comfort care? Do you want limited care? Would you, for example, would you like to have intravenous fluids? Would you like antibiotics? So some limited treatments, but not the whole spectrum of what's available. Or does somebody want full treatment, like absolutely every effort made for them to stay alive? And the third section is about artificial nutrition. If someone is no longer able to eat or has a period of time that they can't eat, do they want to have a artificial nutrition, like a feeding tube, put in? So that one-page form is designed for the patient, or if the patient is no longer able to make their own medical decisions, for the person that they've designated to make their medical decisions. So the patient and their decision maker to go over that form with a physician. And I think often it is a primary care physician who knows that patient and that family, hopefully over time. And then so they review those choices, they check the boxes, and then it is signed both by the patient or their decision maker and by the physician. And then that is a legal form, and it's designed to carry over through different places of care. So one situation that I have often seen is someone who's at a skilled nursing facility. They develop a high fever, they're rushed to the hospital, and the default position in healthcare is to do everything. And this is designed to come with the patient to the hospital, to the emergency room, or for the paramedics to, to see. And then it is the physicians and all other care providers are legally bound to follow what is on the PULSed form. So someone can't, if somebody says, I don't want cardiopulmonary resuscitation, I want comfort care, I don't want all those other things, if they come with that form, or that form is at their local hospital, then the physicians who care for them are legally bound to follow those instructions. They can't sort of decide like, oh well, let's just do everything and talk about it later.
So what I'd like to do is, if we can put on the slide of the 3 different, the advanced directive,
yes,
the PULSed, and the wishes, so people at home can take those websites down. They can find more information there. We obviously highly recommend people to look into those websites.
Can I ask a question about the PULSed?
Can I? Because unfortunately we have to move on to the next part of the program. What I'd like to do right now is, because this is a good segue to what happened to my sister, where she lives in the Netherlands. She lived in the Netherlands because she passed away last year. But they went a step further in the sense of that she was very ill 3 years ago, diagnosed with ovarian cancer, and was told that she probably wouldn't have more than 2 years to live, because it was a very strong type of ovarian cancer that would come back all the time. And so, but based on the system they have there, which they call euthanasia, which actually means the request by a patient for the doctor to end that patient's life. So that's what they call by euthanasia there. And so she was informed about that. And so she did both things. She prepared both for how she wanted to die. At the same time, that gave her the energy to fight like nothing before. She was so courageous. So she started with the surgery, and then she had chemo. And luckily, she responded extremely well to the chemo. Now, she did suffer, obviously. She lost all of her hair, she got sick, the usual, what we, about chemotherapy. But she had herself given, after all the treatments, the opportunity to go away with her husband for several months to Australia. So she was taking the chemo and knew that that trip was coming up. If she did her best, and she wrote about it, how it was going, and then every week there was a lowering of the tumor marker. It was just really phenomenal. She was like in the 400s all the way down to 18. And so the first treatment lasted several months, about 6 months. And then she rested for about 3 months. And then the following year in March, she went for about 2-3 months to Australia with her husband. Had a fantastic time. At the end of the trip, she knew something was going on. So the Monday after the Saturday they'd come back, she went to the doctor, and it was proven that it had come back. So since the first treatment was so successful, she decided to do another treatment. And we know that increasing treatments and having it every 3 weeks and all that, it gets harder and harder. But again, she had then decided that she wasn't going to wait till after all the treatment. She was fighting, and doing all the food that was good for her, and the resting, and still walking, and doing all the right stuff. So she had given her a treat to go, she took a little trip to London with her husband, and to Paris, and some of us gave her money so she could go, to Luxembourg and Portugal, whatever it was. So she came back, and she did these little trips, came back, did more chemo, rested for a week or two, and then she fought real hard. And then it came back again. And then the treatment didn't work. And then she did an experimental treatment. And what happened with her was she developed fluid in her chest cavity. And so she experienced what might be her last part of her life, being gasping for air, And she said it was so scary. So I asked her, is it time for me to come? And so finally, after about 2 years, she said, yes, come now. And so I came, and she was in the hospital, and they were extracting the fluid, which gave some relief. But she had already told us that if it happens again, she was going to do the euthanasia. And she had talked to her doctor. She had told the doctor that she wanted it. If it came too far, that it was too much struggle. And the doctor had, put everything in her chart. Then she stopped all treatments because nothing was working anymore. And then she talked to a second doctor who had nothing to do with the other doctor or her, to independently verify that she had a terminal illness. She had expressed frequently that she wanted to have euthanasia, and to make sure that she fell within those guidelines. So she met with that person, but right before that, my other sister and I met with her at her house, talked about all kinds of things. And so she told us what was going to happen with the second doctor. And she said, and I have to tell the doctor that I want, and then she looked around, she looked at us, and she looked around. And so we said, euthanasia. She said, oh, yeah. I said, and then we all started laughing. I mean, so she said, I better not forget that word, right. Because, if I can't say what I want, I'm not going to be able to do this. So we laughed, we cried, all that. So everything was fine. And so I left in the meantime on July 11th. And so she had asked, to have the euthanasia. And so she had the following week, on the 18th of July, we'll never forget, she had a wonderful lunch with her husband, his sister, best friend, and her husband, a whole really tight group. And, her husband wrote us that it was the most beautiful lunch they'd ever had. And then the doctor came. And the doctor is the person who actually gives her the medication. And he said to us in an email that it didn't take longer than 5 minutes. It was exactly what she wanted, because it was becoming too unbearable. And during that time, she fought, and then she prepared for her own funeral. She made sure that everyone came to see her, one more time. Everybody got a turn, we all got an appointment. It was just really good. It was a real goodbye. And so I feel very sad my sister's gone, but at the same time, I feel that she had a passing that she had envisioned. And it was okay with her, and it was okay with us. And so even though we're grieving, we are missing her terribly, it's a complete story. It's done, it's over with, and she'll always be with us, but not
suffering.
Not the suffering. I mean, yes, there was suffering, but not at the end.
Absolutely.
So that's her story. So that was indeed way different from your story.
Absolutely. The amount of dignity that we feel when we think of your sister's death is just overwhelming. It's just powerful. Powerful. And for her husband and for her sisters.
So, and then of course we did some study, and then we find that Oregon, of course we know about Oregon, and a lot of people know. I mean, of course there are 4 other states also, but Oregon also has, and we actually have a video clip that we're going to see right now, and it's called How to Die in Oregon, and it's a trailer of an HBO special, and it's 2 minutes and 37 seconds long. So why don't we watch that right now?
Okay.
Yeah?
Great.
Okay.
Before you take the medication, I'm going to ask you these 2 questions again.
Sure.
You have the right to change your mind.
My mind's not changing.
And what will this medication do?
It will kill me and make me happy.
Death with dignity. The other side calls it assisted suicide.
I was diagnosed with cancer. I was supposed to have 6 months.
Hi, Sue. These people have lost so much control, and they'll tell us repeatedly they want the medication for control.
It's this curious limbo. You don't know what's really going to happen, except with Death with Dignity, you do have some control over what's going to happen.
An online survey of physicians showed 50% in favor, 42% against.
We have a tradition in this country to allow patients to deny care, but we've never allowed physicians to actively take somebody's life. That's not the practice of medicine.
First do no harm is going to be different for every patient.
So how are you feeling?
Harm for some patients is saying, no, 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 you've got to do this the way your body decides as opposed to the way you decide.
My son has a little trouble with this.
She says the cancer's come back, I have 6 months to live, and things are going to be fine. That sounds like the opposite of fine.
If I'm in that bed and I'm racked up with a stroke, that's what I want. That's the decent thing to do. So for once in my life, I'll be decent.
If I had an option, I would prefer not to die. Thank you very much.
The Oregon law has been thoroughly tested. Now it's time to get it going in other states.
I just think a society has to be asked, is this what we really want?
My husband did not feel that any government or any religious leader had the right to tell him how long he had to suffer.
I understand there's a kind of dignity in suffering, but there's a certain grace in accepting the inevitable. I can't do anymore.
I think all of us would like to have some options of how we'd take control of our life at the end.
It is an hour and 20 minutes long, and I found the trailer on YouTube, and people will have to find it. But it's a beautiful film discussing, all the ins and outs and the requirements also. And maybe we can talk a little bit about the requirements in Erin, in Oregon, and we'll find some similarities when we talk about the situation in the Netherlands.
In the Netherlands,
because basically both of them says you have to be terminally ill, otherwise you don't qualify, and you have to be able to live 6 months or less, otherwise. In Oregon nor in the Netherlands, you can request the help. And in Oregon, you have to ask 2 oral requests and a written request. Right. And there has to be a wait of 15 days in between. And you have to talk to a physician in both countries. And you have to convince the person that is what you want. And that you do it under your own volition.
Right, without any duress.
No pressure from anybody. And if you're depressed in both countries, the doctors are obliged. The protocol says you need to refer this person. Mm-hmm. And not just because a person is depressed and you need to refer this person. And you have to be informed about all the alternatives. Because there are, and such as the palliative care. And so if after that, in both countries, if people still want the help, they are entitled to the help. And what's your response to that?
Well, I think it's, as a physician, I have a California license, and assisted suicide is illegal in California. So that is certainly my medical perspective on it. I feel very grateful to the citizens of Oregon that they have put this into effect, and I think that their experience has been very reassuring. It is used very little, and even for the patients who go through the whole process with the oral requests and the written requests and are seen by 2 physicians, and they make sure that they're not depressed, and they make sure that their pain is well controlled. We don't want anyone to feel like they want to die because of uncontrolled pain or because they're terribly depressed. Yeah. I think in the materials that I was reading about this, they made a distinction between being hopeless and being depressed. And hopeless it's hopeless that your condition is ever going to get better. And And in Oregon, you have the choice to say, okay, I don't want to go through to the very, end with, having to suffer through all the symptoms, having to be totally dependent on other people for care, maybe being unconscious for the last weeks of my life. Mm-hmm. So I feel very grateful that Oregon has conducted this kind of experiment for us, and we can see that a lot of what people feared, that it would be used a lot or it would be used inappropriately on people who were disabled or who were chronically ill. Mm-hmm. I think that hasn't been the case in Oregon.
No. No. And
so that's very reassuring to me.
And it was interesting to see recently that it came into the news, CNN and all the major networks talked about Brittany Maynard,
right,
who was from California, mm-hmm, and has a hopeless terminal illness.
A brain cancer, I believe.
Brain cancer, glioblastoma, grade 4. It's the worst you can get. And so she decided with her family to move to Oregon and establish residency there. Because that is one of the requirements, both in Oregon and in the Netherlands. Yeah. You have to be either a resident or have a long-term relationship with a physician there. And in Oregon, you have to actually have a residence there, either voting, driving, have a home.
Pay taxes.
Pay taxes, mm-hmm, any of those
mm-hmm
things. Now, what I'd like to do is I'd like to show the second clip, which is more of a personal clip of one person, and his name is Robert, and he actually died of HIV, and I thought it was very moving in the way he expresses his experience. So maybe we can watch that right now?
Sure.
Good?
Yeah.
Robert Schwartz is dying at age 50. He has AIDS and many complications from it. He has been close to death several times over the past 10 years. He is on his way to Oregon Health Science University Hospital to pick up a lethal dose of 90 secobarbituls, prescribed legally under Oregon's Death with Dignity Act.
And remember, you will have said all your goodbyes to people, mm-hmm, and you will focus on drinking this in about a minute or less. Then when you're done, you can talk more. Okay. But don't stop to talk along the way, or you will fall asleep and you won't get it all in.
I feel much better that I have it. I don't feel like I have to scramble at the end.
Surely goodness and mercy shall follow me all the days of my life.
These are the secobarbitol, and there's 90 of these. Basically, within 5 minutes you're in a deep coma, and there's pretty much no return from there. This is my pill cabinet. So when I'm asked how do I feel about those pills, they're just pills. They're just pills that are going to do away with all those pills.
It is not just simply an easy method of calling up your doctor and saying, I want to use law. The procedure in and of itself has built-in safeguards. the 2 oral requests, 1 written request, 15 days separating the first and second oral request, 2 doctors to say that you have less than 6 months to live. Either doctor may insist upon a psychological evaluation if they think that you're doing this because you're depressed or you're mentally impaired in any way. And then you have to sign a 48-hour request prior to getting the prescription that has to be witnessed by 2 people. Now, we've gone through 4 people, 2 independent doctors, 2 independent witnesses, all of who are seeing what you're doing, 15 days separating it. That's the procedure in and of itself, which has the built-in safeguards.
We've got 1 subject unconscious, not breathing, pinned in the vehicle.
For 17 years, Robert was an EMT, riding ambulances and dealing with medical emergencies.
I began to see death firsthand. That's when I started thinking about it and how much pain they were in. They asked for help. They wanted help. They wanted help with the pain. Help me die. I mean, I can't help you. I can help my dog. I couldn't make, you know, I can make that happen. I can't do it for you, though. And it never made sense to me.
Showing you the 5 wishes here and the polls. And I hope that if people want to get some more information, that they'll be contacting me at mrand@communitytv.org, and we'll show it again at the end of the program, because I think we're touching on many people's sometimes fears about what's going to happen to them at their end of their life. There are choices in the sense of, in California with the POLST, the 5 wishes, the Advance Directive, and talking with your family. Because the report of the Dying in America shows that there's too few people that really talk about those things. And you know, we all know that we don't know when we're going to die. It may be young, it may be when we're 99 years old. Mm-hmm. So it's important for us to have those conversations and let our family and our doctors know what we want. Now, in the United States, in 5 states, in the Netherlands, and there's probably some other countries, euthanasia, as we call it in the Netherlands, we don't say it over here, it's called aid in dying in many of the states, because we don't want people to get a negative feeling about the word the word euthanasia. So, but in the Netherlands there are some other safeguards, and they actually have, when a doctor performs the euthanasia, the doctor has to file a report. And that report, and we can maybe see it on the slides, some of the differences between the Oregon and in the Netherlands. Last 30 years, people have talked and talked and talked about this. It took that long to get the law passed in 2002. The criminal code includes the euthanasia and the exemption, because as you know, in California, assisted suicide, as it is called, it would put you in prison.
Right.
And so the Netherlands has put it into the criminal code to exempt doctors from criminal liability if they follow the protocol. And it is really amazing. They've done studies, and about 99% of the doctors do follow the protocol. And we know before the law was passed, it did happen. But there was no protocol, and some doctors did end up in jail. So now that it is a protocol and people follow it, there are so many safeguards in it so that it will make sure that I, as a person who is either dement or depressed, or somebody is in my will, that I don't get pressured into requesting that my termination of life. And it also means that even though I may be a patient and I may even be at the end of my life, I need to qualify. I don't have an absolute right to euthanasia. The doctors will review all the information. But it also means that the doctor is not absolutely required. It's not the doctor's duty. If the doctor says, I'm not doing it, then the person can go to another doctor. But it is so another safeguard, and doctors can follow their own conscience. The last difference between the two countries at this point is that the Dutch system is a healthcare for all, which means that insurance does fully cover the palliative care, as well as the terminal care, in this case, the euthanasia. So there'll be other discussions about this in a following program that we're going to do, because today we're basically at the end of our time. I'd like both of you to kind of sum up in a minute what this meant for you, and so take a minute to kind of make your concluding remarks.
Okay. I was telling Mathilde that when I was in school, one of my philosophy of sport teachers had us, as an exercise, go through our wishes for the end of life. And it was difficult as a 30-year-old. I just had a child, recently married, was not thinking of death and dying at all. But it was a really important exercise. And I think that the American public needs to have more opportunity to discuss the physical aspects of dying, above and beyond the religious, above and beyond the philosophical. What do you want? What do you think your end of life should be? And I think it's an important discussion for everybody to have.
I absolutely agree. I think it is a difficult subject to discuss at any time. However, it really opens up the subject to talk with family and with close friends about dying and about your wishes, what's valuable to you, what you want if there is a choice at the last part of your life to be able to take advantage of what's important to you. So I completely agree, and I think that this is a special time. I think that this is sort of bubbling up in our national consciousness, and so I think this is the time to take advantage of that, and not just with your doctor. I mean, it's important to talk about this with your doctor, but talk about this with your family and your friends.
So again, I want to say thank you to both Erin and Dr. Chalea Massion for being here. As I said, we will do a follow-up program. If you'd like to give us feedback, please give us at mrand@communitytv.org. And if you want more of the information that we shared today, I'll be happy to email it to you. So thank you to the all-volunteer crew, Gail, Annie, John, and of course Keith, the director, and Lynn and Karen in the control room. This was Human Rights Here Now. Thank you for staying with us.